I just want to say thanks, Ellen, for inviting me, and Orrin, and I know a lot of you here, and I know we've spoken before about some of these issues, but it's always an honor to be given the time to talk about my thoughts and my experiences. So I'm very glad to be here. I'm very glad to hear the conversation that happened yesterday about the doctor-patient relationship, because I think as we go through my presentation, I'm going to focus on a lot of the same things that we need if we're going to get our ideas heard and implemented, and there is a difference. We can be heard, but if it doesn't get implemented, it doesn't do any good. If we're going to be heard and implemented, we need to be talking about people. We need to be talking about people at every step of the way. That's why most of us do what we do, whether we're in public service or not. It's because we care about people. We care about the people that work for us. We care about the customers we serve. We care about the people we represent. And so that's how we have to talk about these issues. And so as we go through my presentation, I'm going to constantly bring it back to why a different set of ideas other than what's promoted through Obamacare is really needed to help people that we all care about and that we all agree need our help. So for anybody who says that Medicaid is the solution to health for poor people, they haven't seen this graph or this map. And this is a map of South Carolina. The same map exists for every other state. But what it is essentially is a map of all adults on Medicaid in South Carolina, and it takes a look at their relative health. And essentially we put together a basket of chronic diseases and said, depending on where you live, we're going to categorize you as red, white, or blue. Blue means you're healthier than the state average, much, much healthier. Red means you're much less healthy than the state average, and white means you're at about the state average. Now, what you can see here shouldn't surprise anybody in this room, because we talk about this I-95 corridor a lot. There is a broad swath of deep, deep red, which means that these individuals are much, much less healthy than the rest of the state. And you see the blue areas, which again shouldn't surprise you, because this is where a lot of the population lives, but also where there's a lot of good jobs and good education and so on. These are the places where people are most healthy. Now, remember, this map is of people with insurance. This map is people with Medicaid. And yet we see these gigantic disparities depending on where you live on your health. And so it's not insurance, it's not Medicaid that's making the difference in these people's health. It's something else. And so as we did this data with our own group over at USC, we started to ask the question, well, if it's not Medicaid that makes the difference in these people's health, what is it? And as we started to dig into it, lo and behold, somebody else, one of the nation's leading public health thinkers, really one of the world's leading public health thinkers up at University of Wisconsin, a guy named David Kindig, was actually doing a county-by-county study of what accounts for differences in mortality across the United States. And University of Wisconsin and Dr. Kindig had created what's called the County Health Rankings that takes a look at 30 or 40 different indicators, not just of health, but of economic status, of educational status, of family status in terms of single-parent households, a whole set of what are known as social determinants, but also a set of healthcare factors. And Dr. Kindig was able to collect these for every single county in the United States, and he asked a simple question: what seems to be most associated with different mortalities between the counties throughout the United States? And what he found really doesn't surprise a lot of public health people, but I think surprised a lot of other people, is that none, absolutely zero, of the medical care factors such as rates of primary care providers or preventable hospitalizations or percentage of people who were insured or uninsured predicted changes in male or female mortality. None of the medical care predictors. Well, what did? He said, well, while many people believe that individual behaviors in medical care are the primary reasons for declines in health, it really has to do primarily with the rate of children living in poverty, the income, the relative income of those in the county, and a percentage of a county's population with college education. So income and education are the two things which are the best predictors and the greatest drivers of good health. Not having a good education so you make better health choices, not having a good income so you can buy insurance, those things didn't matter, remember. These are the things that mattered. The only other actual individual behavior, the only other statistically significant out of all those 30 or 40 different indicators that predicted a difference was percentage of a county that smoked. That was the only other one. Yet Obamacare is designed to take very poor people and put them into an insurance system at a very expensive cost with the idea that it's somehow going to improve their health. But this research and years of research before it just show that that's absolutely not the case. So the fact that we're putting so much money into healthcare, and Ellen referenced it, and the speaker talked about our overall state budget, should worry us if you believe in the research and you believe that it's income and education that are actually driving the health of a state and not how many people necessarily have insurance or have Medicaid. And for the first time in 2009, and this is a graph from a bipartisan group that looked at the state's budgets, in 2009, the lines crossed in terms of total state spending on Medicaid versus K through 12 education. And so we are now spending in a state more of our state budget on Medicaid than we are on K through 12, and that doesn't include the money that we're also spending on the state employee benefits program. Because this is just not a Medicaid problem. It's a health care problem. It's a health system problem. And the state has two very large liabilities related to how the health system is performing. And one is obviously Medicaid, but one that often gets overlooked and increasingly is taking more and more money every year out of the state's budget is the health care benefits for current state employees and retired employees. And so the conversation related to shrinking the size of government in terms of the number of employees is incredibly important because we have very, very large liabilities at the state level related to those employees' health. And every dollar that we spend extra on Medicaid and every dollar that we spend extra on the state employees' benefit program is less money for K through 12, is less money for roads, is less money for early childhood education or higher education, whatever you're interested in, all those things that truly drive health. So it should worry all of us, and I know it does, and this is where I'm going to start switching into actually the solutions, but this analysis I think is important. It should worry all of us that this logic tree that Obamacare was built on it's a very tenuous logic model. The Obamacare program was built on the idea that there is a one-to-one relationship between health insurance, access to effective health services, and then good health and well-being. But in fact, it is not a one-to-one relationship, and that this formula breaks down at many, many places along the way, but that is essentially ignored in the Affordable Care Act. And so what our job is to do is to, one, recognize the difference between health insurance, health services, and health, understand where we need to invest in each one of those and how we need to invest. And so that's what we're trying to do at the state level as much as we can without federal interference. The big question I referenced, this isn't just a Medicaid problem, it's a health system problem. The big question is, for me, being the head of a Medicaid program which right now covers over 1 million people in the state, is why isn't Medicaid producing better value? Why do I have those big red swaths? Why do I still have, and I have a lot of data I could show you, but I don't have enough time, why isn't Medicaid resulting in the health improvements that we really need for the system? One is because the health system itself is broken. The reason why we're spending so much money on Medicaid is because the health system right now is operating on a model that maybe worked for 30, 35 years, and that was their model, where we needed to build a lot of hospital beds, where we needed to build a lot of nursing home beds, because that's how we treated people. But now we have all that infrastructure built, and we have bonds that help pay for that infrastructure that hospitals need to make bond payments on. We have loans that are outstanding that hospitals have to make loan payments on. But the model that we need now, that we've needed for the past 10 or 15 years, is not that heavy infrastructure, heavy hospital-based model. It's a public health, preventive health, outpatient-based model. But the problem we have is that as the value of that old model starts to decline and the value of the new model starts to increase, there's this gap that hospitals and hospital systems have to jump to go from this heavy infrastructure-laden, heavy employee-burdened, heavy physician-employed model to this new, lighter, more nimble public health, preventive health, primary care model. And the question is, who's going to pay for it? Now, every industry in America faces this same problem. We could take a look at the auto industry, and I'm originally from Michigan and saw the auto industry go through 2 major failures in Michigan. But just our recent bankruptcies of GM and Chrysler are a good example of this. Everybody, GM, Chrysler, and Ford, have jumped that gap. They jumped the gap from being these very costly, poor quality, building big SUV-type systems to being much more nimble, building smaller cars with a much less of a union burden that they are today, that are more competitive. How did they get there? Well, GM and Chrysler, to get across that gap, said, you know what, we're going to go bankrupt and we're going to ask the taxpayer to pay for it, right? And so we all pay for it. Ford, what did they do? They mortgaged the Ford logo and they paid for it themselves. They didn't put the taxpayer on the hook. So the question is not, are we going to jump the gap, and not how we jump the gap. We will jump that gap. We will get to the system we need. But the big question right now, and if you talk to a lot of hospital administrators, is who's going to pay for it? They want the taxpayer to pay for it. And I've been in conversations with folks to say, I need Medicaid expansion because I need to pay to be able to jump this gap. I've got all these bills to pay. I've got bond payments. I need that $1 trillion of Medicaid money that's flowing in the next decade in the United States to help me pay for that. But that's not necessarily the best way to do it. There's lots of other ways to get over that gap, and I don't think we should automatically default to the taxpayer paying for it, especially paying for it through a program like Medicaid that is not producing good health for the people it's designed to serve. Medicaid is not designed to be a provider entitlement program. It's designed for the benefit of the individuals that we all agree on are most in need. And so one big reason why Medicaid is not working is because the health system's not working, and we're facing this significant problem right here. Now, why Medicaid doesn't work separate from the rest of the health system, thinking about just Medicaid and thinking about poor and disabled individuals that we deal with, there's some very specific reasons. First is because healthcare providers and, frankly, the state are not prioritizing those most in need. I think one of the conservative principles we need to run a healthcare program is that we have to set priorities, and we have to live by them. We can't. We all recognize that there are certain folks who need our help, and I have never talked to anybody in this state, conservative, liberal, that disagree that individuals living with disabilities, profound disabilities, don't need the state's help. There's no disagreement among anybody about that issue. There's also very, very little disagreement about very, very poor children. It's when we start to get out into these other areas where all of a sudden we bring in pregnant moms, and then we bring in adults up to a certain income level, and now Obamacare wants to get all adults up to 100. This is where we have the disagreement, but there's no disagreement at the middle. But yet, we can't agree. I think Republicans can agree, but most Democrats can't, that we have to set priorities in government. Who are the populations that most need our help? All of us want to help folks. The program was designed for individuals with disability and very poor children, but now it's getting out here. So the first thing we need to do is we have to set priorities. Providers need to set priorities too, because if you're a healthcare provider, the way we operate now is you just sort of sit back and you wait for people to show up. And if you walk in and you need health care services, we're going to give them to you. If you walk in and you don't need health services, we're going to give them to you anyways because we're afraid of being sued, or we're afraid of poor satisfaction scores, or because we get paid to do it anyways. So, if we can, we'll give you a little bit of health. But the people who most need our help, again, those people at the center of our concentric circle, the people who have profound problems that we all agree the state probably needs to help, they're sleeping under a bridge somewhere, or they're shut in their house somewhere. And the lieutenant governor is doing a tour right now speaking about a lot of the elderly who aren't in the Medicaid system right now, who eventually end up in the Medicaid system because they're shut in their homes, they're shut off from society, and they eventually, because we're not prioritizing those who are most in need, they deteriorate to such a point that they then come onto the Medicaid system. And so what we really need to do as a state is decide where our priorities lie and then meet those commitments. And then as providers, we need to say, who are the people in the world that we're paid to care for that most need our help? Not just whoever walks on in, let's give them services because that's how we get paid. The second thing is that actually once you get poor people into a system, and again, Medicaid is designed for poor individuals and for individuals with significant disabilities, once you get them into our healthcare system, the system's not designed for poor individuals. The system is designed essentially for middle-class individuals who can answer questions about their health, who can ask questions about their health, who can follow instructions given to them by the doctor, who can get to the pharmacy and get their prescriptions paid, who go home to a well-operating family who helps them take care of themselves. But that's not the system where many individuals that we're charged to take care of live in. They have profound problems actually following basic instructions, describing their own health, taking care of themselves once they get home. And so we can do everything perfect inside the doctor's office. We can diagnose correctly, we can write the right prescription, but once they walk out the door, if it all breaks down because of all these other barriers, what's the point? Why do we spend all that money on a doctor's visit that the minute people walk out the door, it doesn't have any practical effect? And that's what's happening right now. And so again, the Affordable Care Act is trying to shove everybody into this system that's not designed for them. And from a Medicaid perspective, that absolutely makes no sense to us. And so we're going to talk about our strategy, and our strategy focuses on a few things. One, prioritizing. We have to prioritize the individuals who we think there's agreement that the state needs to provide help to. We can't provide everything to everybody, and that's what somehow Obamacare is trying to do right now. Two, we've got to design systems that actually work for these people, and that doesn't necessarily mean a Medicaid insurance system. Giving someone a Medicaid card is not a guarantor of health, as you saw on that very first map. And then third, I consider it one of my most important jobs is to control cost inside the Medicaid program so more money can be diverted to other important investments. And so the legislature can decide to invest more in roads. The legislature can decide to invest more in education. The legislature can decide to send some money back to the taxpayer. Now, I believe in that because that is what drives health. I've been told by legislators before to not talk about those things. You shouldn't be talking about education. You shouldn't be talking about sending money to roads. You shouldn't be talking about economic growth because you're just health. Well, as a healthcare professional, as a public health professional, those are the things that drive health the most, and they can't understand that. And so if I'm working hard to control the cost of healthcare so the legislature can have more money to invest in these other areas, and so individuals and business can have more of their own money to invest in these areas, that is a health program. And that's one of the, sort of the central tenets of our strategy. So I'm running to the end here, and I've got all sorts of great lists of things to talk to you about. I talked to you about our broad overall strategy, but there are many things that we're implementing that go to meet our commitments, that go to really get to the health of the individuals that we're taking care of and not just pretending that we're serving them because we've enrolled them in Medicaid. I think the reason why Obamacare is so easy for so many people because it's just a choice of expand, don't expand. Spend more money, don't spend more money. Give people subsidies, don't give people subsidies, and that's going to fix the system. But the real truth is that it's an incredibly complex set of interventions that we have to put in place to actually improve the system. It's not one size fits all. I complain that the federal government tries to treat the states all the same, but I go county by county, and I get the same complaint about the state trying to treat all the counties the same. Every county in this state is incredibly different from each other. And so to think that we can set a federal policy that somehow makes sense for individual counties. I mean, we have counties in the state where the infant mortality is 3 to 4 times the infant mortality of the county right next to it. We have counties in the state where there's 10 times as many doctors as a county only 25 miles away. And so there are incredible differences in the counties. And so every one of these programs here is designed to intervene at that local level specifically for those local individuals and that local population. All of these programs are also designed to ultimately lower the cost of health care. And so when we talk about payer-provider relationships, for instance, one of the things we're doing is we're working with Greenville Health System, and we didn't mandate it, we didn't write it into law, we didn't write it into policy, but we encourage Greenville Health System and Blue Cross Blue Shield to work in a partnership to actually share risk to manage Medicaid individuals. And now, instead of the incentive being to spend as much money as possible, because for every new procedure and every surgery and every doctor visit you actually make money, now they're in a partnership that every dollar they spend is actually a dollar lost. And so they're working together to try to figure out ways to keep people out of the hospital, to try to keep people from having expensive surgeries, to keep people from being readmitted after surgery. And they're doing that completely in a free market, no government ACOs, no nothing. It's their own private choice. We're part of Catalyst for Payment Reform, which is made up of some of the largest employers in the United States, Boeing, GE, 3M, Walmart, Marriott, who all have a very large employment base. And we're the third Medicaid agency to join that group. And what we're doing is working with major employers to actually reform the way that we pay for health care. And so again, instead of paying doctors and hospitals to just generate more and more visits, we're actually, along with employers, and none of this is government directed, to actually pay for value. And so we're actually one of the leading groups, and Catalyst for Payment Reform just paid for research along with the Milbank Foundation to take a look at one of our major initiatives in terms of improving birth outcomes. Because poor birth outcomes don't only affect the Medicaid program, but they affect Blue Cross Blue Shield and employers as much as it affects us. And so the private sector, Marriott and 3M and Boeing and so on, are taking a look at what we're doing in Medicaid in terms of improving birth outcomes. And so being involved in these private partnerships that are built on aligning incentives is moving us much more quickly down the road than any government grant that we're getting to pilot something, and moving us much, much further down the road than simple Medicaid expansion ever could, because we're actually targeting individuals and we're targeting problems and we're targeting communities to work on their health care problems. So improving value, which is lowering costs and improving outcomes, ultimately allows us to divert money to invest in state education, infrastructure, economic growth. It allows us to shift some money from unproductive healthcare spending to productive healthcare spending, and it also lets us take some of that money and cover some vulnerable and exposed populations that we haven't been covering. Because if you do believe in the social determinants model where 80% of health is driven by income and education and personal choices and family support, there is the other 20% where coverage does become important. That doesn't mean coverage under an insurance model, and it certainly doesn't mean coverage under a model that Obamacare presents, which is a major expansion of Medicaid, regardless of whether you need health care services or not. But when you need health care services, you need health care services. And so if there are people who cannot pay for health care services, who need our help, we can get them those services. We have lots of ways to do it. It doesn't have to be through an one-size-fits-all expansion. My final slide is really to let you know what I think we need from the federal government. We're going to continue working on improving value in the system. We can't pay attention to what's going on up in Washington. So we're working locally to continue to improve value, lower cost, and improve outcomes, to try to understand what's happening with the massive shifts of insurance in the state so we can make better decisions. We're finding populations that do need our help, which we can't leave behind. And we're looking towards 2017 when we have a waiver flexibility from the affordable government or from the government for the Affordable Care Act. I think lots of people are ignoring that there's a 2017 date where we can, under the law, get out from under the law. And so it's not simply a repeal strategy. It's not simply a collapse upon itself strategy. There's actually ability in the law to get out from under it. And so we're targeting that date to get ourselves out from under the Affordable Care Act. What we need from the federal government, what we're going to ask for from the federal government in 2017, earlier if we can, is we need more flexibility in return for more accountability. The two are not separate. So what we need is we need the government to, some people call it block grant, some call it a per beneficiary, per month payment, but we need predictability. We need to change Medicaid from being an open-ended entitlement to something that both the state and the federal government can predict. In return for that predictability, we want to negotiate with the federal government, because they are giving us, in our case, 70% of the bill, so they deserve to have some input into it. We want to negotiate outcomes, not mandates. I've got a contract with the federal government that's that thick. That's how big my contract is. It covers every single action I do every moment of the day. 99% of it means nothing. It means absolutely nothing, but it employs thousands of bureaucrats. What we really worry about is outcomes. We worry about the number of premature babies. We worry about the number of people dying from heart disease. We worry about the number of people who are obese. And so in return for that flexibility and predictability of a per beneficiary per month or per year payment, we're willing to negotiate actual returns with the federal government to say our program will produce these types of returns, but you have to give us the flexibility to do it. You can't, one, hold us to contract requirements such as lowering, the state's obesity level by 10%, and then every step of the way try to prescribe how to do it from Washington. And finally, we need to align incentives that reward outcomes and efficiency. And the system right now is designed for states to try to figure out how to spend as much money as possible to draw down as much federal money as possible. And a lot of supporters of the Affordable Care Act say, well, that's the great thing about the Affordable Care Act. We can get all that money from the federal government. Think about all the jobs it'll create and everything else. Well, the money that it brings down for health care jobs take jobs away from manufacturing. They take jobs away from tourism. They take jobs from everybody else and put them into health care. And so we need to change those incentives. And there's actually some very interesting proposals on the books that are bipartisan. I'm working with other Medicaid directors from red and blue states to actually do these things. And so that's the direction that we're going. So I'll be happy to answer more questions during the question and answer period, but I really appreciate your time.